All righty. Good afternoon, everyone. Welcome to the California HPV Vaccination Learning Collaborative. Today is our last session of 2025, but don't fear, we are coming back in 2026, and I'll talk about that at the end of the webinar. My name is Shantae Davis Patterson, and I'm going to be your moderator today. Um, just a few housekeeping notes here. We have muted everyone and we ask everyone to please mute yourself and be respectful of our presenters today. And you can unmute yourself to ask a question once we get to the Q&A part. You can also ask questions in the chat box. We will be monitoring that. The webinar is being recorded. And as always, we would love for you to fill out our evaluation because it does help us improve our sessions. So today our icebreaker is, what is one of your most used emoji or reactions that you use during meetings? So please, as you introduce yourself in the chat, please include your name, organization, pronouns, your role, and let us know what that emoji is that you use all the time. All right, so this learning opportunity is being brought to you by the Engaging Health Systems and Providers Work Group of the California HPV Vaccination Roundtable. And what is the HPV Roundtable? For those of you who are new to the Learning Collaborative and haven't joined us before, the California HPV Vaccination Roundtable is a coalition of diverse stakeholders with a mission to work together to prevent HPV-associated cancers and precancers by increasing the California HPV vaccination rate to 80% by 2026. And our website is cahpvroundtable.org, so you can learn more if you go to our website there. All right, so our agenda today, I'm going to give just a couple of roundtable updates, and then we're going to have a wonderful presentation titled Beyond the Intervention, Long-Term Impact of HPV Vaccine Strategies by our guest, Dr. Gina Johnson. Then we'll do a Q&A period, and then we'll close. All right, so just a couple of updates from the roundtable here. First, the announcement approach training. You all know that this work group is the coordinators for the announcement approach training. We do have CME credits available now. This training presents strategies for recommending the HPV vaccine to promote vaccine acceptance and save clinical time. It's designed for providers interacting with parents. You can learn the latest on HPV vaccine research and guidelines, as well as brief evidence-based communication. The training is only 1 hour and it's online and it is free. So contact us if you want to bring this training to your practice. We're happy to do it. You can get CME credits, and again, it's free. And then just a reminder that California HPV Vaccine Week has passed. It's always the first week of August of every year, and our Increasing Parent and Community Knowledge Work Group has pioneered this awareness week. But the good thing about this awareness week is all of the materials that are developed are useful all year round. So we still have all of the resources up on our website. So you can visit our website. Joyce is going to drop that into the chat, but you can find a social media toolkit, campaign guides where you have newsletter, email content, all of the things. And Dr. Gina Johnson is actually featured in some of our materials for the HPV Vaccine Week. So go ahead and check it out and use them. They're great resources all year round. All right, and now I would like to introduce Dr. Gina Johnson. We are going to drop her bio in the chat so you can read more about her, but I'll just give her a quick introduction here. So Dr. Gina Johnson is the medical director of the pediatric of for pediatric. Excuse me. Let me try that again. Dr. Gina Johnson is the medical director for pediatrics at Northeast Valley Health Corporation. She began her career there in 2001 and has served in a number of physician champion roles. In 2017, Dr. Johnson became the medical director for pediatrics and has led the implementation of a variety of projects, including a PCORI UCLA study on system interventions to increase HPV vaccine uptake. She serves on the board of directors of the Immunization Coalition for Los Angeles County and is a member of the Los Angeles County Community Prevention and Population Health Task Force. You can read more about Dr. Gina Johnson in her bio that will drop in the chat. But now, without further ado, I'll turn it over to Dr. Gina Johnson.
Thank you so much for having me, and it's a delight to be here with you, and it's really fun to see some of our partners from that PCORI study. I see Dr. Herman and Dr. Vastani are on here, so thank you. You will recognize many of the slides that I'll be sharing today. And we can just go straight to the slideshow if we're able to. Beyond the intervention, long-term impact of HPV vaccine strategies. I am, as mentioned, the pediatric medical director at Northeast Valley, and we did have a wonderful PCORI sponsored study with UCLA that lasted a little over 5 years. And now we're a couple of years out and we're trying to maintain that work. And so this is beyond that intervention, how we can continue to maintain that work. So next slide, please. Thank you. So Northeast Valley is a federally qualified health center in the Northeast San Fernando and Santa Clarita valleys of Los Angeles. That's where the big earthquake was in 1994. And this beautiful picture is actually the building that we built after the earthquake because of, thanks to the funding we had to rebuild and make things even better. Next slide. So you'll see that there are a lot of questions that you are welcome to drop your answers into the chat here. And that's sort of the way that we've engaged our staff on these trainings that we've provided as well. So what percentage of people will get an HPV infection in their lifetime? 40%, 60%, 85%? Yeah, next slide. You guys are on it. 85% of people will get an HPV infection in their lifetime. And so this is an incredibly important question for us, how we can improve HPV vaccination rates so that these infections will not occur and that they will not result in cancer. Next slide. So the study that we had with UCLA was on the comparative effectiveness of systems interventions to increase HPV vaccine receipts in our federally funded health center. So it's from November of 2018 to 2023. Yep, right through the pandemic. That was us looking at the study of how we could improve receipt of the HPV vaccine. We looked at parent reminders versus clinic-based interventions, and we looked at the effectiveness of combining both. Also looked at some subgroup analyses, and we to let the cat out of the bag. Yes, they work a little bit, which is great. And we'll talk more. Really, this is going to be talking about the in-clinic interventions that we put into place and how we've been able to maintain those over the years. So next slide. So as I said, the study took place right in the middle of the pandemic. So you see, we went from in 2020, November of 2019 to October of 2020 was when we started our clinic-based intervention, and things got interesting over that time. And we were able to extend the study a little bit beyond October of 2022 into 2023, which was really helpful to see if, what an effect we could have. So next slide. So again, we're really looking at what were the in-clinic goals that we had as opposed to the parent reminders, which I think Dr. Glenn shared about maybe a year ago or so. This is really looking at how we were intervening within the health centers to improve our delivery of the vaccine. And what we knew based on our data was that we're pretty good at initiation of the HPV vaccine, and we will talk about how we get there too to initiate initiation, but we really wanted to improve that vaccine completion rate. And we noted that one of the big concerns was missing opportunities. Patients were in the health center, especially as COVID got up and running. So once we were able to get patients back into the health center, we had a lot that had missed visits because of COVID. They had virtual visits. They weren't actually in the building. So we wanted to see how can we get those patients that are in the building to get vaccinated. And we shared this broadly with our health centers that missed opportunities, any visit when a dose is due and they don't receive the vaccine. Thankfully, refusals are not very common in our patient population. Only about 5 out of 100 times would they refuse the vaccine. But of course, those are the ones that stick in the minds of our clinicians and our care teams as well. And so we just wanted to really encourage our teams to vaccinate at every visit. The next slide shares what were our clinic-based interventions. So we had a standardized clinical workflow, which I'll be sharing in a moment here. And then we had annual in-service trainings at the intervention health centers. And many of these slides are from those trainings, and I'll be sharing a little bit more about that as well. We also sent a missed opportunity report specifically to our clinicians for monthly, how often they had a patient in the health center or on a virtual visit, and we'll talk about that in a second, who did not receive their HPV vaccine. And then we had monthly meetings with our team and had some joint observations at the health center by our UCLA and Northeast Valley team. The trainings that we had, our in-service trainings, included our vaccine guidelines. We talked about clinic level vaccine administration and missed opportunity rates and documentation, particularly around the documentation of refusals or if the vaccine was not available for some reason. We talked about the use of a recall system, and I will share a big win for us here at our health center on that. But again, because our initiation rates were relatively good, and you'll see them in a second. But we wanted to be sure that we were getting our second doses in, and so we needed to have a system in place to remind the patients to come back in at that 6-month visit. And we also had a really fun, which you'll get to see here, a role play activity that we included in the training. Next slide. So this was the typical agenda from one of our in-services. So we talked about the importance of the HPV vaccine. We talked about our missed opportunities when the patients were in the health center. And then the EPOD is our reminder system that they were entering the patients into to remind them that they were due for a second dose in 6 months. And then reviewed our Northeast Valley standardized vaccine workflow. And we talked about some examples of the HPV vaccine. So next, so here's another chance for interaction. How many cancer cases in the U.S. are caused by HPV annually? Your choices are 5,000, 37,000, 11,500. You guys are on it. Look at you. Yes, indeed. 37,000 cases annually caused by HPV. So this was our standardized clinic workflow in the next slide. So we wanted to be sure that every single visit, every single time, whether the patient was in the health center or not, that we had the care routing slip available and reviewed by the clinician who was seeing the patient. We talked about giving a strong recommendation for the HPV vaccine at every visit type. So again, sick or well, we wanted to be sure that they were given that recommendation for the HPV vaccine. We wanted to be sure we documented all vaccine refusals in our electronic health record. So the way that we pull our missed opportunities is from the electronic health record. And because we use the care routing slip for ordering our vaccines, it was really important that our care team entered the result of that vaccine offering into our EHR in order for us to electronically pull an accurate report. And then we asked them to schedule recalls using our recall system or the EPOD system for any follow-up dose due over 3 months, and then a nurse visit for any patient who was due within the next 3 months. So our health center practice is not to schedule appointments more than 3 months in advance because we find that we wind up with a lot of missed opportunities. And because we don't have, we wind up with a lot of missed appointments, and because we don't have a system for our nurse visits where they're getting a message if they didn't show up for that appointment, we did not want scheduled appointments more than 3 months in advance. So if a patient was 15 or older, they were receiving their first dose of the HPV vaccine, which was a very small portion of our patients, then we would have them schedule their nurse visit. Or if they came in and it had been 4 months since their last visit, their last HPV vaccine, and they were going to be due in a couple of months for their next dose, then we wanted our nursing staff to schedule we wanted our care team to schedule a nursing visit so they could receive that vaccine. But if they were in that more than 3 months out, then we were asking our care teams to enter this information into an electronic system in our computer, which was super challenging, actually. And this was our big win. One of our biggest wins was actually we were able to automate that system by the end of our study. And so now our care team does not have to go into a separate part of the computer system and enter that the patient is due for another vaccine. All that they have to do is make sure that they enter the first dose, and then our IT team figured out a magical way for us to put them into a log, and after 3 months they're going to receive a phone call saying, or a text message actually saying, it's time for you to schedule your next appointment. Please call the health center, and then they're able to schedule that nurse visit. So very exciting. Yeah. So this is a one that I think our experts will not all know the answers, although a few of the people on our call may know. What was the HPV vaccination rate at Northeast Valley when we started this study? So again, as I mentioned, our initiation rates were 83% when we started in 2019 versus 72% in California and 53% in the US. And our completion rate, for patients that were due for their second dose, so we chose the age 12 because assuming they got their first dose at 11 years and 6 months, by 12 years, they should certainly have completed their second dose. So if California was at 66% when we started and the US was at 49%, what do you think Northeast Valley was at? You can just give a guess. Higher or lower than the US? Higher or lower than California? Yeah. Melissa, I love you. I wish that we were at 93%. 75%. Yep, you're getting closer, getting closer. You can go to the next number. We were at 56%. And so we were doing a great job of getting that first dose in, but we were not doing an excellent job of getting that second dose in. By the time we finished, so December of 2022, so we were not quite finished, but almost, we had a 90% initiation rate and we had a 68% completion rate. And that was, again, post-pandemic. So pretty exciting for us to see that we had improved that. Next slide. So we also shared at these annual in-services what the missed opportunity rate was for our in-person appointments. So you can just imagine that all of us say, oh, that must be the other health center that's not doing such a great job. We get 100% of our patients that are in the building vaccinated, no problem. And what we found and was very helpful was to actually be able to share with the health centers that we were less than perfect. And then really we've also found that a little bit of healthy competition goes a long way. So letting them see what the missed opportunity rates were at another health center as compared to theirs was really highly motivating towards changing behavior. And again, particularly because we needed to have the right data in our electronic health record, it was really motivating for our care teams to say we need to document correctly if it was actually a missed opportunity or if we just didn't document so that we can get good numbers here. So next slide. So these are a few more of the slides that we shared. And the first step in our HPV vaccination workflow was to print and review the care routing slip. So very, very important for us. And we found, based on our our observations and data gathering was that actually we were very good at Northeast Valley organization wide about printing and reviewing those care routing slips. But we did at each of the annual in-services ask for any feedback or questions on the areas that they would recommend that they thought we could improve on even more. So. Next slide. This is really talking about how we delivered a strong recommendation. You're actually going to see live and in person how we modeled that or did not model that. But we talked about routinizing and bundling the vaccine recommendations. So we included HPV, Menactra, or your MCV vaccine and Tdap. We bundled those all three together, which is, a little bit of a conversation that we continue to have over the recommendation that you can begin offering the HPV vaccine at the age of 9. So it does take away that opportunity to bundle, but it does also offer other advantages. But anyway, at the time, we were really focusing on routinizing and bundling the vaccine together and avoiding particularly singling out the HPV vaccine. When we discussed the HPV vaccine, we really wanted to talk about focusing on cancer prevention as opposed to sexual activity, because parents of teens do not like to think about their children having sex. Emphasizing that less doses are needed if the series is initiated at a younger age. So I just had a patient the other day in the office where the mom has been refusing the vaccine for her. And, I explained to the mother that actually, if you give the vaccine at a younger age, it actually is more effective and they need fewer doses. So a great way to help children get on board with the shot question, fewer shots, they always like, and emphasizing the importance of getting all the shots in the series. So we talked about this routinely in our training every year. And now you get to see a video of, I'll just share, you can go ahead and go to the next slide, but why we put this video together. This was, again, you can tell by the masks, height of COVID. And originally at our annual in-services, we would have the care team or, the care team and their clinician or the person they're sitting next to at the in-service pair up, and then they would practice together. But when COVID happened and we had to switch from in-person in-services to Zoom in-services, we came up with this wonderful idea of creating a video. So it's a little dated because it's clearly 2020, but there you go.
Joyce, now we can't hear it. Oh, there it goes. Now we can hear it.
Do you have any questions about the vaccine? Isn't the HPV the vaccine for sex vaccine? Yeah, but it's optional. The school doesn't really require it. So you can get it if you want your child to receive it or not. Okay. Yes. Here is the information. You can look over it. Just let me know if you decide to get it or not. I mean, it's not like your child is going to have sex right now or anytime soon. And, like I said, you're the parent. It's your option. If you don't want it, don't even let the doctor know about it. Okay? Thank you. You're welcome.
Yeah, so you missed the very first part of it, but she did, and we'll talk about it, but she did say, your child is due for the Tdap, the HPV, and the Menactra vaccine, and then she went on. And so then here I come to talk more about HPV vaccine.
So we're going to give you your child the vaccines today, the Tdap, the HPV, and the Menactra vaccine. Isn't the HPV vaccine for the sex vaccine? Well, it prevents a sexually transmitted infection, but we like to give it before they start to become sexually active because you never know what they're going to do. We want to make sure that they've gotten the vaccine in before they start doing any of that stuff they're not supposed to do. Okay, thank you.
Yeah. So next slide. So feel free to chat in or come off mute or whatever. What did you like about this role play? Anything that could be improved? And this is actually.
I think it was great and it worked really well. Yeah. Yeah. And the other thing I like about Dr. Johnson is she doesn't scare people with her white coat. She comes in kind of at the level of patients, and so the interaction is very easy and positive because they're not intimidated. And was the same with I think it was your MA, right?
Mm-hmm.
It's the same thing, just very calm.
Yes. And I see there's a few comments about sandwiching the HPV vaccine between the MCV and the Tdap. Yes, anything that could be improved, certainly changing the conversation from sex to being related to the cancer prevention. Yeah. And the fewer doses. And several types of cancer, yep, instead of sex. Yeah, hi, Dr. Kampa. And I see your hand is raised. Emelu? Miss Emelu?
Yeah, thank you so much. My question is specifically on gender disparity that exists with HIV and not HIV, HPV vaccine. I wanted to know whether there is a specific tailored approach that NEV is using to address HPV disparity among men, because usually by default, when we talk about HPV, it defaults to cervical cancer, but there's other part of cancer that are more disproportionately affect men regarding HPV, and how are you guys communicating that to parents and to be able to bridge that gap?
Great question, and thank you for asking. We actually did look at our rates, our vaccination rates for males and females, and we're able to, address that question. And then one of the questions that I did not share, but in our annual training, one of the questions that we asked was, which cancers does HPV vaccine prevent? So very specific to all 6 types of cancer, and so that you could have that answer at the ready for any time with either a male or a female patient. But we did not target our language towards either gender, and we did not specifically talk about cervical cancer. We just talked about cancer in general, because again, parents don't like to think about their teens having sex, whether it's a girl or a boy. So just making it general cancer prevention is actually, we found to be quite effective. All right. Next slide. So this was sort of the end of our in-service training. Was our main takeaways. Recommend a strong recommendation focused on cancer prevention. So I didn't mention, but we actually had 2 sets of videos. The first set you saw, and the second set were a more specific to using our strong recommendation and using these recommendations. So we did give them a positive example as well. So a strong recommendation focused on the cancer recommendation. We talked about vaccinating at all visits. We talked about the importance of documenting the vaccination status so that we would be able to actually collect that data and have good data, and then to schedule those follow-up doses. So that was December of 2023, and we're 2 years later. What is happening here at Northeast Valley? We have a couple of measures. One that we look at, and I'll talk a little bit more about it with our quality improvement team at our quarterly meetings, looking at adolescent immunization, which includes the percentage of children 13 and over who have completed their first dose of the meningococcal vaccine, a dose of the Tdap vaccine, and have completed the HPV vaccine by their 13th birthday. So just as a reminder, we were looking at by 12 to 17-year-olds who were up to date, but now we're looking at this measure, which is a quality improvement measure for up to date by age 13. And you can see that we had a steady increase in the post-pandemic years, 2022, 2023. And by the time that the study finished October 2023, we were at 65.9% of our adolescents being up to date. And we have essentially maintained that number and gone up a little bit more by Q3 of 2024, we were actually at 68%. But Q2 of 2025, this year, we were at 64% of our adolescents, all of the Northeast Valley adolescents that had come in, that were up to date on this measure. And you can see that we have this data also by health center. So again, we could promote that friendly competition to see which health centers are being more effective at getting their adolescents vaccinated. All right, next slide. So, and I very much appreciate our UCLA team working with us as we were transitioning from completing the study onto being all on our own again, and seeing what we could sustain, what processes we could put in place that were clinic-based processes that would be effective to maintain our vaccination. And so some of the sustainable processes that we were able to continue was the quarterly review of our immunization rates at our CPIC meeting, and that is shared with our clinicians at our monthly pediatric provider when that data comes in. And we were able to continue with observations in the health centers. The immunization team and our operations team have combined their observations, and they do those quarterly in the health centers to see, for instance, is the care routing slip being printed? Is it being utilized? And then we send out now these quarterly missed opportunity reports to the clinicians. So again, based on data for patients that came in to see them at the health center on that the last month or so, which patients were due for their vaccine and actually got their vaccine. And so it actually has a place, and you can't, this one doesn't have it because it didn't have virtual visits, any virtual visits, which we're not seeing a ton of, but it has a place for in-person visits as well as for virtual visits. And it tells you how many patients were seen, how many received the vaccine, how many refused the vaccine. And they also at the same time receive a list of specifically which patient charts were audited. So they're able to go in and look and see what they did or what they, how they could improve. Next slide. And so we're adding some new stuff. Since we finished our study, we now have a monthly immunization task force that meets to understand how we can further improve all of our vaccine rates and what we can do to improve our care delivery to all of our patients at all of our health centers. We are also adding our medical assistant to the missed opportunity report. So we are working on getting, because it's so important for our medical assistant to enter the vaccine correctly and to be able to see which patients we truly did miss, then we're going to be able to we're creating right now a report for them that will be sent to the individual medical assistant as well as to the health center clinic administrator and nursing supervisor. So we've got a missed opportunity report that's provider specific and MA specific. We have been sending an HPV outreach text message, which was part of our reminder system intervention. We continue to do that. We do quarterly observations, and then our IPA also helps us send some live calls to patients who are turning 13. So that is what we have implemented so far. And then the last slide here shares some of our future directions. We're going to want to do our annual immunization in service, and we're going to modify it to include specifically some motivational interviewing to address vaccine hesitancy. So back also during the height of COVID, we were able to be a part of a innovation challenge looking at specifically improving COVID vaccine rates. And as a part of that, we have many trained coaches in our health system who are trained in motivational interviewing and coaching. And also we have a specific curriculum around vaccine hesitancy and using motivational interviewing to help patients. So I think it really addresses, I know that there's a question here in the chat about countering the messages from our current HHS secretary and ACIP. I think the beauty of using motivational interviewing is that we're really meeting patients and their families where they're at and understanding what their motivation might be to get their child vaccinated. And so, of course, we can counter the messaging that's out there that is inaccurate, but also we can, by delivering good information, accurate information, but also we can help align our patients and their parents' really purpose for coming into the health center with vaccines. And then again, we're also looking at improving documentation of immunizations in our EHR, in our electronic health record, to assure the accuracy of that missed opportunity report, so that patients, so that staff will be really very invested in assuring that they are offering those patients the opportunity to get vaccinated at every single visit. And that is all that I've got for now. So I welcome questions. And I think there was a question in the chat earlier about promoting or implementing cervical specimen self-collection at clinic or in-home. So I'll just say that we are not doing self-collection at Northeast Valley, but I think it's a great opportunity, especially for our adolescents. And we do have a teen health center at a high school. I think that would be a great opportunity.
Thank you so much, Dr. Johnson. So now is the time to ask any other questions of Dr. Johnson. You can come off of mute, raise your hand, drop your question in the chat.
Can I ask a question?
Yes, please.
So, Dr. Johnson, there was a question about girls versus boys and the HPV vaccine. Could you share what the rates were with both and how unusual Northeast Valley is with respect to this and why?
Thank you. Great question. And I actually do not have at my hand.
I mean, you don't have to say the exact numbers, but you know.
Yeah. But essentially our male and female rates were equivalent. So we did not find that we had a significant decrease in the male rate versus the female rate. And I think that, it really comes out of our culture, which is to say that we offer the vaccine to every single patient. And, when we're talking about cancer prevention, again, it's not so much about like, are you going to get cervical cancer? Are you going to get penile cancer? Are you going to get oral cancer or anal cancer? We're talking about preventing cancer. And so the families generally accept that.
I mean, that's pretty unusual given national data, right? That the boys are far less likely to get it. And so this kind of shows the approach that Northeast Valley has taken that is successful, which is sort of, treating everybody the same. If somebody asks questions, you answer, what are the cancers, you can tell them. Somebody says, but I thought it was only for girls. Then, Dr. Johnson has really good response for that. But you don't start treating them separately. And I'm very impressed to hear that.
Thank you. Yeah. Yes, I think I shared once a story of a patient that I went in all set to convince them that they needed to get their HPV vaccine, and they were actually concerned about a different vaccine at all for their son. But like the families are willing to get it pretty consistently across the board.
Great. I do see another question in the chat, Dr. Johnson. Is the HPV vaccine going to include additional HPV subtypes in the future? And then there's some examples listed.
I actually cannot say. I'm not certain, but I bet there's someone on the call who has a little more expertise than I do in that. No.
Is
I
anyone?
haven't heard anything about including extra subtypes because the largest number of cancer cases and chronic HPV infection is from these subtypes. And then, Dr. Johnson, can you speak about the trend towards one dose that we're seeing worldwide? And
Yes,
maybe
yes. So I definitely can speak to that. So you know, in some places, including Mexico, I think they now have recommended just a single dose of the HPV vaccine because it is actually very effective at preventing the development of cancer from HPV. So you know, it may be at some point that even in the US we will align with that and have just a single dose.
So it's a kind of also a lesson if it's really hard to get people come in for the second, and then if they're older, a third, at least get them the first dose.
Yes, I see Dr. Herman.
Hi, thanks. And thank you, Dr. Johnson, for always coming through and sharing important information. I'm curious about kind of what's been going on over there. When we were doing this project that you shared about, we saw among some parents with the COVID vaccine coming that they felt like a little less worried about HPV vaccine because COVID vaccine was new, which was sort of a unexpected positive thing. They're always worried about the new vaccine on the block, if you will. So have you seen that change? Has it affected hesitancy? I know there was another question a little bit related to hesitancy with, you know, kind of what's going on nationally, but what are you seeing?
Yeah. I mean, so we did definitely see that there was a big shift from concern about the HPV vaccine to more of a big shift about the COVID vaccine. I think bundling continues to be very effective for us. When we say, you know, you're due for some vaccines today, and then the patients maybe, or the parent maybe asks, you know, which vaccines, and we do that sort of sandwich, Tdap, HPV, meningitis vaccine. You know, this season we're talking about COVID and flu as well. You know, it continues to be that HPV has just become a very routine vaccine. So we're still experiencing significant concerns around the COVID vaccine. And we actually, VFC is just shipping out COVID vaccine for pediatrics this week. So it's been about a month that there's been a gap without having to having the COVID vaccine available to give to our patients. But that's definitely the one that we experience the most hesitation even. And I think, you know, as we make things more routine, and I know that's the challenge, particularly around COVID vaccine and the messaging that's out there right now. But as we make things more routine, it seems like our families are just, you know, more willing to get those. So I had a patient just the other day who came in and 11 years old, and he was due for 3 vaccines, and his mom told him, you know what, your older brother got all 3, your older sister got all 3, and you're going to get all 3. And that was the conversation. So it really does make a difference that they've seen now many years and been able to see that the side effects are non-existent and that the decrease in cancer rates, we know that the decrease in cancer rates has been quite significant.
All right. Well, thank you again, Dr. Johnson. This has been a wonderful session, and thank you for everyone contributing to the Q&A. We just have a couple of more slides here. As I said, we're going to continue this learning collaborative in 2026. So Joyce has dropped the links in the chat. Once you sign up, and if you are already signed up for this one, you should already have access to the 2026 sessions as well. And you can also view past recordings on our website. And then for our last announcement, I'm going to turn it over to our colleague Raquel Arias from the American Cancer Society to talk about our annual meeting.
Hello, can you all hear me?
Yes, we can hear you, Raquel.
Okay, thank you. I'm having a little interface issue. Thank you so much, Dr. Johnson. That was an excellent presentation, and thank you all for joining today and for your active participation. So as Shantae has mentioned, this quarterly series is, of course, brought to you by the California HPV Vaccination Roundtable, specifically the Health Systems and Providers Work Group. So shout out to that work group. Thank you so much for hosting this series for several years. But we wanted to let you all know that the California HPV Vaccination Roundtable 2025 annual meeting is coming up on December 10th. It's going to be in downtown Los Angeles this year. This meeting is open to, first of all, members of the California HPV Vaccination Roundtable. That includes work group members. And then for the last couple of years, we've had a general membership option. So many roundtable members are on today, and you should have already received the information about this meeting. And then this annual meeting is also open to other California-based stakeholders working to advance HPV vaccination. So we wanted to bring it up today for those of you that are on but aren't on our membership list. We don't generally promote this annual roundtable meeting widely. We generally stick to dissemination through those on our membership list, just largely because of space and budget limitations. But we wanted to share with this group because we know there's a lot of important work happening among you, and wanting to give everyone the chance to benefit from this content, network with others, as well as learn more about getting involved with our state roundtable. So if you're available or you're in the LA area, or it's feasible for you to get to the LA area for December 10th, we encourage you to consider joining us. And yeah, let's see. Yeah, in the chat, you'll see the link to our event landing page, and you can certainly reach out and ask any questions. Thank you. Hope to see some of you there.
Thank you, Raquel. I know we're at time. Thank you again to everyone who has joined us, and especially to Dr. Johnson. Please complete our evaluation, and we will see you in 2026. Thank you all.